Okay. Thank you, everybody, for joining us this morning. My name is Kathleen Hoagland. I am a Program Representative Supervisor in the Division of Program Support and Quality Improvement at DDAP. We are thrilled that there is such a large group this morning. I'm seeing almost 100 folks on here, and we've got quite a few coming in as we get started. So really excited about what we're going to be talking about today. You might notice that we have a guest here, Jeff Thomas, the CEO of White Run. He's going to be doing something in a minute here. I'm going to go through just some housekeeping items, and then I'm going to turn it over to Jeff. Just a reminder that we always encourage folks to submit questions on the topic that's going to be presented to the ASAM resource account in advance of the call. So we did not get any questions this time. We did get a couple questions this weekend and then even this morning, but we did not have time to prepare answers to those questions. So in advance or in the future, please submit questions to the resource account in advance of the call. We will try to answer those throughout the call. This call is being recorded. I did give folks an opportunity to leave the call today if they were not comfortable with being recorded. If you're not comfortable, please exit right now, and rest assured the content from this call will be available at a later date on the ASAM transition website. And if you have suggestions for future call topics, you can also send those to the resource account. We're really excited about getting those suggestions, and please think about that and send anything our way that you can think of. Just a disclaimer, and we kind of do this in the beginning of every call, is that alignment with ASAM criteria is required of drug and alcohol treatment providers that are funding for providing treatment services with single county authorities and/or managed care organizations. And really want to stress the importance today of reviewing the ASAM text and attending those ASAM trainings that are available. We are going to be providing an overview today, as we usually do during these calls. These overviews do not replace kind of really reading the text, understanding it, attending these trainings. Again, these are just a resource, some technical assistance to help providers in the alignment with the ASAM criteria. All right, so I'm going to just do a quick introduction here. We have Jeff Thomas, the CEO of White Deer Run, Alan Wood here today with us. We are really excited about him being here. So he and his program were the site of the first pilot for the ASAM alignment reviews, and he has graciously agreed to speak to the group today about their experience with that ASAM alignment pilot #1. And so very excited to have Jeff here. And without further ado, I'm going to turn it over to Jeff.
Thanks, Kathleen. Hi, everyone. So I wanted to talk to you today about our experience with the pilot survey. We were the first facility that I'm aware of under 3.5 to have an ASAM alignment survey conducted. And so, we wanted to be first at the table to see what we could find out. We all know there's been some confusion around this. This has been a big project, and trying to get everybody on the same page, I imagine, is very difficult. But at this point, we have some good information to share with you today, and I'd like to talk to you about the steps in the survey and what it was like for us. So first of all, the survey had 3 parts. So part 1 was pre-submission materials. DDAP and OMSAS provided us with a list of things that they needed, and I'll talk about the content of those in a minute. The second part was an on-site review where they did staff interviews and a tour of our program. Not much different than what you get from a DDAP survey. I mean, you typically look around the facility, you talk to the staff. So that was very similar with a slightly different focus, more on ASAM alignment. And then part 3 was the site review of the patient files, and that was essentially to validate application of the ASAM standards to the service delivery. Go ahead, Kathleen. So the pre-submission materials, they included policies and procedures, staff lists with credentials, staff training, staff schedules, and program schedules. And that allowed them to take a look at how we had modified things to meet ASAM alignment requirements. Kathleen? So for the on-site interviews and tours, the staff that participated in the survey were my key management and clinical staff. We had 1 representative from DDAP, which was Kathleen, We had 3 representatives from OMSAS, and if I get this right, it was Benny Varghese, hopefully I pronounce that right, Lynn Wright, and Shivani Patel. Right. And then from the SCA, we had a representative from Lehigh County. That was, let's see here, Molly Stanton. We had a representative from Magellan, which was Anita Kelly, a representative from Beacon, and that was Jesse Mayfield, and then CCBH sent Rebecca Sedlock, and many of you may know these folks. So we had a good representation from multiple agencies. Kathleen? So I'll give you a real quick overview of our facility. I apologize to those of you who are from the CTC or opioid side of the business or the outpatient side. We are strictly an inpatient detox and rehab, so 3.7 WM and 3.5. And 3.5 was the focus of our pilot survey. So we have 282 3.5 beds. All of those beds are DDAP and RTFA licensed for both co-occurring capable and co-occurring enhanced. And we mix our clients within our facility. We think that treatment should be a microcosm of the rest of the world, and that mixing clients together gives better perspective for both groups. Same thing applies to our MAT patients. Those clients are also mixed with clients who are from, a total abstinence model. And what we do is we take 282 beds and we break them down into 6 smaller rehab units within the larger complex. Kathleen? So this gives you an idea of what one of those smaller units looks like. The blue boxes represent changes that we made relative to ASAM preparation. The yellow boxes are what existed prior to the ASAM alignment. So we did in fact add a behavioral health technician. We added a lead counselor as part of a career ladder change. We wanted to give our counselors an opportunity to move up the ladder toward unit supervisor or clinical director. And so we opened a position for a counselor and we added a lead counselor. And the way that that works is on a 65-bed unit, each counselor has a caseload of 10 and the lead counselor would carry 5. Now, those numbers can vary. I mean, they may drop on certain days or they may climb on certain days, typically plus or minus 3. But these are the targets that we set. We felt these were reasonable to accomplish ASAM alignment. Kathleen? So some of the things that we wanted to talk to DDAP and OMSAS about were the challenges that we face. All of the providers on this call know exactly what I'm talking about in terms of challenges. We were already faced with a COVID pandemic, trying to manage all of the things that go along with that. At the same time, trying to figure out how are we going to provide 7-day-a-week service somewhere around a 6 to 8 hour per day, using 40-hour staff who would have to cover 52 hours a week. So that made it very significant challenges for us. And that also included extending to weekday. So since the COVID pandemic took place, nobody wants to work second shift or weekends. Everybody wants to work Monday through Friday. They want to work 8 hours. They don't want to work overtime. So all of those issues have created some problems for us in terms of trying to figure out how we're going to staff this. And then on top of that, finding licensed or credentialed staff, or finding staff who come in at the entry level who can meet those requirements in the allotted time frame. That was another major concern of ours. And then adding evidence-based treatment. We were already doing that. We had been doing that for a number of years, but we felt like we needed to beef up that process. So that added additional training time to an already difficult schedule. And then reimbursement. As we all know, reimbursement has not kept up with expenses. Inflation was at an all-time, I think 11 or 12% this past year. Reimbursement did go up this year for the first time in a number of years, but it still did not keep pace with inflation. And it was trying to cover for a couple of decades of under reimbursement. And then on top of that, the workforce challenges. So people would schedule interviews and then never show up for the interview, because they were trying to collect unemployment, and as long as they had an appointment, they could say to their unemployment representative, yes, I've been seeking a job, I've had multiple appointments, but they never check to see if they attend those appointments. So that's presented some challenges. And then, of course, the nursing shortage, that goes without saying. Everybody here knows about that. Trying to find qualified nurses and then compete with large hospitals that are paying anywhere from a $5,000 to a $26,000 sign-on bonus. We recently found out that one of the hospitals is paying a $26,000 sign-on bonus for RNs. And so we can't compete with that. And then, of course, with Medicaid clients, increase patient acuity. We are seeing more homeless folks during the summertime than we've ever seen. The winter is going to pose additional challenges. Patient aggressiveness is at an all-time high. Mental health and physical health acuity are also at an all-time high. And so we talked to this, we talked to the team about difficulties that we've been having with patient aggressiveness, patient assaults on staff, and so forth. And then lack of basic needs. We have patients coming in without money, resources, clothing, etc. Kathleen? So we also talked to them about the implementation of interventions. So we added 3 counselor positions, 5 behavioral health technicians, 1 full-time psychiatric nurse practitioner, a family program counselor, and then we had 2 other positions that had been open for a while that were prior to ASAM, but were going to be very pertinent to the ASAM alignment, and that was an acupuncturist and a Reiki program facilitator. The other thing we had to do because of retention concerns, we want to retain people who are credentialed or who are working toward credentialing. We also want to make sure that staff who want to become credentialed have a way to pay for that up front. So we're now paying for their ability to apply to get their credentials, and we're doing that so they don't have to lay any money out on their own. So that's a risk, right? Some of those folks may decide to leave once they achieve their credentials. So we wanted to create a career ladder system so that staff could excel at our agency and stay with us. And so that helped us create the lead counselor position and a couple of other positions within the organization. So you can technically go from a technician to a case manager, to a counselor assistant, to then a counselor, a lead counselor, and then a supervisor. I personally started here as a technician, and I'm now the CEO of the agency. So to be able to talk to our staff about, you have that same opportunity here. So we felt that was going to be critical to our stability. And then finally, creating a licensure or credentialing track for our staff. Okay. The interventions that we did, we conduct weekly chart auditing of 100% of our charts through our medical record department. We have modified unit schedules. We added more robust activity program and recreational programming. We added additional family services. In spite of COVID and non-visitation, we're doing a lot with video conferencing for our families. We also added pre-admission screening training for our call center and our local admissions teams, and a significant increase in evidence-based trainings for all direct care staff. We had the Beck Institute come in and do a training for us. We added de-escalation training to take care of high acuity. We also have the Glasser Institute that comes in here generally every other quarter to provide training for our staff. And with House Bill 253 grant, we were able to distribute a real nice paycheck to all of our clinical direct care staff for staying with us and hanging in there through COVID. We also added patient involvement in certain types of documentation, and this was a key for us. Our biggest question was, how in the world are we going to document all the services? We've been offering about 6 hours of treatment every day, but how do we document all of that? We simply don't have the time or the staff to document everything that we do. And so we came up with this idea, and Kathleen, if you want to go ahead and advance to the next slide. Yep. So we took some structured group activities. Now, we don't do this with all of our notes. Group notes and individual notes are all done in our electronic medical record. Those are completed by the qualified staff. But for structured group activities, we may do things like a morning meditation. We have pastoral services. We have activity staff, those folks will use a form that looks something like this. And the way this works is we fill out the patient's name and their counselor's name, the start time and the duration of the session, and where it was located. And then we talk about what type of group it was. And this one was a daily meditation. And then in the data section, we ask the patient to complete that portion in writing on a piece of paper. And it covers things like, what was today's topic? How did this activity support your treatment plan, goals, and recovery? And then there are a couple others like, what did we learn from today's session? If it was an activity program note, they would document what activity they took part in and how that contributed to their recovery goals. And we were very surprised to find out how positive the comments were. So in this case, you have a gentleman who says, overcoming triggers and being conscious of himself. What did I learn from today's session? That much effort is required to maintain sobriety. And then how did this activity support treatment goals and recovery? Reinforces my acceptance to overcome addiction. And I'm not sure what that word is, but help and securing counsel. So, this is one example of some of the notes that our patients write. Many of them have surprised our clinical team. And what they've started to do is when they meet with the client individually, they'll look at that week's notes and identify some patterns in that. Sometimes you'll have a patient that says things like, the topic was meaningless. I didn't learn anything today, and this isn't helping me because I want to leave. So if they write something like that, the counselor can then work with them on AMA intervention, get the family involved, talk to them about how they ended up in a rehab program and so forth. But this has been very successful, and we find that our patients don't complain about it. They're willing to fill out the documentation. Once the data portion is completed, they sign it and date it. That's evidence that they attended. And then the staff will fill out an assessment, which includes some checkbox areas and a comment field, along with a plan for what's to happen next. So we're using this for about 2 hours a day to cover things like I said, activities, daily meditation, recreational activities, goal setting groups, and so forth. Kathleen? So the third part of this was chart reviews. And so DDAP and OMSAS and the health choice representatives had an opportunity to look at our charts. We selected a couple for them to look at because our clinical team was proud of some of the work that they've been doing. And then they randomly selected, I think it was 7 or 8 other charts on top of that for a total of 15 charts. Kathleen? So here's what the survey told us. And I'll be honest with you, when we walked into this, we weren't sure what to expect. There was a fair amount of anxiety about how are we going to look? What do we need to change, and so forth. What we found was a team of people that were very collaborative. They offered their insights and their guidance as they had been throughout the process. We've been on the phone with Kathleen multiple times, and we've been going back and forth in correspondence as well. And that was helpful in getting ready. We also found out they weren't punitive. They didn't give any indication of a plan to be punitive. They focused on finding evidence of individual care. They weren't looking for a black and white tally of hours. So we kind of expected them to come in with a notebook and check off, okay, on Monday they had this many hours and on Tuesday they had this. That really wasn't the case. I mean, I'm sure there was some awareness of the hours that they were seeing, but we brought that issue up and they said, you're too focused on the number of hours. It's a recommendation, but what we're really looking for is that you've increased and expanded documented services. Have you done the intent of ASAM alignment, which is to provide more care, to provide care in a way that is ASAM specific, and are you using evidence-based practices to do that, and then recording that in the chart? Now, that's an area of weakness for us. We need to work more on delineating evidence-based practices in our writing of the notes. For example, today I met with this patient. They are talking about leaving treatment prematurely. I used a motivational interviewing technique to talk with them about that. And the patient has committed to stay for another 24 hours. Those types of things are things that they're going to be looking for. What practices are you using? And then they looked at services to be real patient specific. So one of the things that I was concerned about is we have certain groups and individual sessions that are scheduled throughout the day. They have to attend a group every day, a small group. Many of our units are 2 groups per day, depending on how they have those configured. And so if a patient doesn't attend a group, they write on the note, patient was not present in small group today because they were meeting with the MAT nurse to discuss their Suboxone MAT. We were concerned that if they were missing that particular hour of group, that might be something we get tagged for. Instead, we were pleasantly surprised to see that the team said that's exactly what we want to see, because you're modeling the program to meet the needs of the patient, not to meet the needs of the program. Now, they've been talking about that at all of these meetings, but wasn't really clear what that meant. And it became very clear during the survey that that's what they're going to be looking at. It was also reassuring to my team that we've made good progress. Having said that, there's still work that we need to do. I mean, we want to provide great care for our clients. We want our patients to leave the program and say, I really like White Deer Run. And any of you who look at Google reviews, you know, you don't get great reviews from patients. Usually what you get are people who are disgruntled and they leave and they want to punish you for something that happened in treatment, whether it was something you did purposely or not, or whether it was something that, something that they were disgruntled about and felt it was unfair. So it's difficult sometimes to get those types of surveys and have patients feel really good about the care they received. Kathleen? So that gives you kind of in a nutshell what our experience was like. We walked out of that meeting feeling pretty good about it, feeling more prepared than before. I know many of you have asked, what does the tool look like? That was one of my goals, is to get a copy of the survey tool. We were not successful in doing that because the team informed us that tool is still under development and will undergo a number of revisions prior to being released. But they did assure us that eventually we will all get a chance to see the tool and know what the expectations are. So with that, I'd like to open up for any questions that you might have.
Thank you, Jeff. That was wonderful. And yes, if anybody has any questions, we are allowing some time right now for that. So you can either raise your hand or you can type your question in the chat and I will unmute you if you want to raise your hand. I see hand raised, so I'm going to go with, there's 3 people, so I'm just going to go with the first person that I see, which is Judy. Judy, you should be able to unmute yourself and ask your question. Go, Judy, you just unmuted yourself. Just do it one more time. There you go.
I didn't even touch it. Am I there?
You're
Okay.
there. Yes.
Sorry, Jeff.
Hi, Judy.
As I was listening to what you were saying, and some of the, especially when that MAT discussion came about, my question is, are you seeing any challenges related to aligning yourself with ASAM and still meeting some of the licensing requirements?
So not really. The licensing requirements are kind of a general framework for policy and procedure and expectations. ASAM really just adds a layer on top of that. So I think that in and of itself is the challenge, just trying to figure out how to add that layer with the resources that we have. But the truth is, we've been doing most of what ASAM talks about all along. I think this is more of a fine-tuning process, and I don't think we knew that until recently. So I hope that answers your question.
Yeah, thank you.
Thanks, Judy. All right, I'm gonna, I see a question from Greg McConnell. Greg, you should be able to unmute yourself and ask the question. And if you can state what organization you're with, that would be great.
Okay, it's Greg McConnell with Phoenix Domus Men's Halfway House in Altoona. And mine is kind of related to what Judy's question was, but it's more specific to policy changes. Did you find yourself having to make many policy changes as a result of the ASAM alignment, and did that conflict with licensing policies and procedures?
Yeah, so we did not have to make many changes, although I have to kind of give you a disclaimer. We haven't received the official feedback on our policies yet, so we expect that here probably in the next week or so. There may be some surprises in that we weren't aware of, but generally, you know, we've kind of subscribed to the ASAM alignment or the ASAM practices for a long time anyhow. A good friend of mine was director of ASAM for a number of years, and I spent a lot of time in some of the ASAM committees with their detox criteria before they changed the name to withdrawal management. So I have a lot of familiarity with ASAM, and so much of our policy and procedures were written with similar language.
Okay, thanks, Jeff.
Yep.
All right, Jeff, I see. So first of all, there's a question about copies of the slides. And yes, I can reassure everybody that copies of the slides will be available after the presentation today. And then there's a question from Becky asking, what other types of evidence-based practices did you implement for alignment?
So as I had mentioned, one of the things that we did is we received a grant to get the Beck Institute to come in and do a 12-hour training on CBT. Honestly, that was probably one of the best trainings that we've had access to in a long time. Their institute has some really good folks that work for them, and it provided a lot of practical application of CBT. So that was one of them. We've been working with the Glasser Institute on Reality Therapy and Choice Theory. That's something that Coforge Behavioral Health introduced us to. And so we've been working with a woman named Kim Oliver, who's been providing those trainings. They also do some follow-up for our supervisors to train them on how to supervise their staff using those approaches. Motivational interviewing, DDAP provides a really good training on motivational interviewing, and we've been really pleased with those trainers. They've been here a couple of times. And, you know, we also do some rational emotive therapy. That's something that we've used for a number of years. We're also, this isn't necessarily listed as evidence-based, but we're not just doing 12-step recovery now, but we're doing smart recovery as well. We have a couple of staff that are trained in that. And we've been looking at trainings around transgender, LGBTQ, also working on music therapy and some other programming. That's been a big help.
Great. All right, so I have another question here. Florence Page was saying your presentation was very helpful. Can you explain how you are using the client group summary sheet? How does that become a part of the required chart documentation process?
Okay, and I assume that you're talking about that example that I showed. Is that your impression also?
I think so, Jeff, yeah.
Yeah. So what we do is we actually have those in English and Spanish for our Spanish-speaking clients who they speak English, maybe broken English, but they are more able to articulate in writing in Spanish. So we're able to give that to those clients. And what we do at the beginning of a session, we'll hand that out, have them fill out their name and so forth. And then we'll go through the group process. And at the end, we take about 10 minutes where they can fill out their impressions of the group. They can get some help from the staff if they need it, or they can complete it and turn it in. And then we have folks that scan it into our electronic medical record. So we generally have a very large stack of papers every day that have to be scanned in. That's probably our biggest challenge, is not having a way for the patient to automatically place that in our electronic record. If you have a paper chart, it's easier. It's just sorting and placing it in the chart. But we've been doing that for, let's see, it's been probably 9 months now. We continue to monitor those notes, and we've decided that it's going to be a standard part of our practice going forward.
I see another question from Ellen Clark. How did you implement family services?
So we had a family program prior to ASAM alignment, but like some programs, it was more of a secondary thought than a primary. We closed one of our partial programs. We had a director there who was very engaged with families and wanted to take over our family program. So we promoted her. We hired 2 family program counselors, and we started using a lot of video conferencing. So until COVID is over, we probably won't resume direct visitation. We saw a lot of problems with that in the beginning when people were showing up at the hotel positive with COVID or would get COVID and go home and complain. So we switched over to video conferencing, and that's been very effective. Actually, that's given us access to people that otherwise would never have attended an on-site because of the distance. We have some people traveling as far as 5 hours to get here. So the video conferencing made the difference for us and the additional staff.
And then the last question that I'm seeing is, can you repeat where you obtained the CBT training from?
CBT training came directly from the Beck Institute. If you I actually have a contact. If you're interested, you can email me at jeff.thomas@whitedeerrun.com, and I'll be happy to send that contact out to you.
Perfect. I think those are all the questions that I'm seeing right now, Jeff. Perfect. And Tim just put something in the chat as well about some CBT training that we have available. So Jeff, I think that's it. We really appreciate your time today and you explaining this process to everybody. Would you be willing to, if folks had additional questions, could they reach out to you?
Yes. Yeah, that'd
okay.
be fine.
Perfect. And I will make sure that your email address is available to everybody. And
I'll put that in the chat box right now.
Perfect. Wonderful. Thanks again, Jeff. And we can't say thank you enough. This was wonderful for everybody to hear this today.
Thank you.
All right. Going to just go on here. Yeah, that was fantastic. Thank you very much. Hard to follow that, but we are gonna try. So we have about a half an hour left. I'm going to skip over some slides, but I want everybody to be reassured that everything that we have is going to be available on the ASAM Transition website. So all the slides that we had put together for today, including Jeff's, and the recording will be available on the ASAM Transition website. What we want to talk about today in the time that we have left is we want to talk about that, the record review we want to talk about the record review and what that's going to look like for programs who are getting ready for the ASAM alignment review. We're going to talk about tools and resources available to assist you all in preparing and evaluating records for the ASAM alignment review. And we're going to review and understand some key elements of the ASAM criteria that really need to be visible in records when people are coming in to review those. This slide looks familiar because this is a slide that we talked about last month as well. So these are just some really key concepts of ASAM to incorporate across all levels of care. So these really key tenets of ASAM should be visible in the patient record and throughout that patient record. And again, I put some references for page numbers and from the ASAM text, so you can go directly into that text and look at what we're talking about and some of the definition for some of these really key terms. We're going to be talking about a few of these more in depth today. So the first thing that we're going to talk about is the kind of records that would be looked at during an ASAM alignment record review. When people are on site. So please note that the list that you're seeing right here is not exhaustive. There may be other parts of the record that we want to take a look at as well, or agreements that are in place. So these could be agreements, memorandums of understanding, things like that, releases of information. But some of the key things that we're going to be looking at are that biopsychosocial assessment, level of care assessments, treatment plans, progress notes, case consultation notes, and then there's some additional items on here as well. So these are the kind of things that we're going to be looking at as we come in to look at the record reviews during the ASAM alignment review. Evidence of transition planning. And again, we're going to be going into some of these pieces that you're seeing here in a little bit more detail in a minute. This also will look familiar because last month we talked about the resources and the tools that we have available to help everybody prepare. So obviously, number one, and we always talk about this, is the ASAM text. This is going to be your best friend in preparing for the alignment review. The level of care specific self-assessment checklist that we have on the ASAM transition website. The next slide, I'm going to be talking a little bit in more detail about how you want to use these to prepare for record reviews. And then one of the biggest resources that I really want to encourage folks to look at are previous ASAM monthly TA calls, specifically the December 2021 call and the January 2022 call. So the December one talks about individualized documentation considerations, and the January call talks about therapies. So these go into a lot of detail about what you can really be moving towards in preparing for the ASAM alignment reviews and what needs to be really evident in the patient record. So really would encourage you to review these calls with your teams. And again, every one of these has the slides, but it also has the recording. And if there were questions that were voiced during that presentation, then the Q&A is available as well. So a lot of good resources to help you in this. Again, using the self-assessment checklist. So I went through this last month as well, but what you're going to see for every single level of care is that you're going to see a self-assessment checklist and you're going to see a service characteristics list. So I think for purposes of really preparing for the record review, what's going to be very helpful is using the self-assessment checklists that are available for ASAM level 3.5. It is what it is. It's a checklist, right? So these blue boxes that you see in front of you, these are just two examples. So I pulled a snip from the documentation checklist and then the assessment and treatment plan checklist. And I know this is very tiny print and you probably can't see it, but I'm just kind of pointing out what you really should be looking for. This is a checklist. You go through it, it's a very nice way and tangible way to really gauge how prepared the records in your program are for this alignment review. Really encourage folks to take a look at these. And please note that, documentation and assessment and treatment planning are not the only checklists that are available. So they talk about therapies, they talk about staff, support systems, and settings. So please, please, please be using these as self-assessment checklists as you're preparing for the record reviews. They are a huge resource. So we are going to be skipping through some slides today, and rest assured this is available on the ASAM transition website after the call. But I also just want to point out that what these slides are that I'm skipping over, these come directly from that checklist that I was just talking about. So these come directly from the self-assessment checklist. So you can go back and look at the self-assessment checklist. We're going to be skipping through these slides today. They will be available on the website. Just want to reassure everybody that all this information will be available and is available already in existing resources in the text and on those self-assessment checklists. So skipping through a couple slides here, these really just talked about the various therapies that should be available at this level of care according to the ASAM criteria. So not skipping through that section entirely, but just kind of saying this a different way or showing this to you a different way is, and this may also look familiar because this is from a previous ASAM monthly TA call. What you see here under the 3.5 column with an X in a box, that's really, and I really want people to kind of start wrapping their heads around this. Those are really the menu of therapies options that should be available at this level of care. So again, what you see here with the X's under the 3.5 column, these are the therapies that should be available at this level of care. It's a menu of options. I really like saying it that way because not every therapy or intervention is going to be appropriate for a specific patient. But the important thing is that you have this menu or these options available for when it will be appropriate for certain people. So just want to make sure that that's really clear. And again, the ASAM text goes into detail about the kind of therapies that really do need to be available at this level of care. Okay, we're going to skip through a couple of these as well because these all are on that checklist that I talked about, that self-assessment checklist. So it's talking about biopsychosocial assessment and treatment plan reviews, the H&P, the progress notes, care coordination. So I'm going to skip to the meat of this, okay? The first tip I'm going to offer for everybody. So these tips today that we're going to be going through, these are tips for programs that are preparing for the record review for ASAM alignment. So Jeff just talked about this. He talked about really the focus on individualized and patient-centered care. So this is my first tip. In my opinion, it's the most important tip. Individualized treatment that's person-centered and collaborative and really designed to meet the needs of an individual and to match their preferences. And it's really guided services that are directly related to a specific, unique patient assessment. So the foundation of this individualized and patient-centered care is the biopsychosocial assessment. How the assessment is approached and conducted right in the beginning of treatment is really sets the tone for treatment for the remainder of the treatment experience and is the foundation for individualized patient-centered care. So during this assessment, is the staff member explaining what the purpose of the assessment is? Are they explaining the role of the assessment in the treatment experience, how the assessment informs the treatment experience? So if it is the foundation, then it's extremely important to get as much detailed information as possible across those 6 dimensions and to understand the patient and their unique needs and abilities and strengths and preferences. So is the assessment kind of conducted in a way that is collaborative, or is it more somebody sitting at their desk, you know, ringing off a list of questions, typing in the answers, and that's it? And there's really no explanation. There's really no getting to know the person beyond just that list of questions, or kind of maybe going a little bit deeper into certain areas that seem to be a really important and fundamental part for the treatment team to address in this person's treatment. So if this assessment is done well, and really all the elements of that assessment are used to form that treatment plan and to identify interventions, that makes the most sense for the individual. Everything kind of will start to fall into place, but there's got to be an understanding across that whole entire treatment team that individualized and patient-centered care has got to be front and center. It has to be fundamental. So in this slide here, I basically put some examples of maybe ways that a reviewer can really tell if care is individualized and patient-centered. So we can look at the daily schedule. Is it the same for everybody, or is it, you know, really clearly individualized for that person? Are the interventions the same for everybody, or are they tailored to the individual? You know, are we using quotes when appropriate from the patient? How often is informed consent clear in the patient record? Things like that. Okay, going on to tip number 2. People know that I like this idea of the golden thread. I really like using this image when possible. And we have an excellent, I'm just going to throw this in, we have an excellent ASAM treatment planning training that is available. And this is one of the important kind of tenets of that's discussed, is this golden thread of documentation. So I know most folks on the call probably know what this refers to, but when we're looking at record reviews for ASAM alignment, it is incredibly important that everything is related and builds off of one another. So for example, I just talked about the biopsychosocial assessment. It's really important that what is documented in the biopsychosocial assessment is then, you know, really clearly tied into the treatment plan, and it informs the treatment plan. And then the treatment plan and the biopsychosocial assessment are really, like, you can tie back the progress notes and the interventions used to both the treatment plan and the biopsychosocial assessment. So it's extremely important that throughout the patient record, we can see this kind of commonality across the documentation. So if I'm a reviewer and I'm coming in to look at the record, I can it makes sense to me why this session focused on this particular topic and why this intervention was used, right? I can see it because it is tied back to the treatment plan and it's tied back to the biopsychosocial assessment. It's not fragmented. So just kind of a different way of thinking about the golden thread, or just laying it out here. This was also talked about in a previous ASAM monthly TA call on individualized documentation in very simple terms. And I'm just going to say it again a little bit differently. If a problem is identified in the assessment, it's clearly seen in the treatment plan and in the progress notes. And if a new problem emerges during treatment, it is noted in the progress notes. Maybe the assessment is updated, the biopsychosocial assessment is updated, and then likely added to the treatment plan. So just this kind of common theme throughout treatment that we see everything kind of relating to the next thing. Assessment relates to the treatment plan and to the progress notes, and then opposite, progress notes relate to the treatment plan and to the assessment. And when new information comes up throughout that individual's time in treatment, we see that it is actually factored in, that there's something done about it. It's not ignored. It's used to inform that individual's time in treatment. Third tip here is medication-assisted treatment. So, and I know that somebody asked a question about this during Jeff's talk earlier. So we know that MAT will not be appropriate for every patient. Just want to make that really clear. So knowing that, we know that MAT will not be appropriate for every patient, but we know that MAT is an evidence-based treatment and it will be appropriate for many patients. And so with that said, at the very minimum, there should be evidence that MAT was discussed with the patient, informed consent. So pros and cons of the various types of MAT were provided to the patient. Education was provided to the patient. There is clear record in the, there's clear evidence in the record that the interdisciplinary team is closely following the individual's progress or lack of progress on MAT, maybe adjustments that need to happen. And this is being discussed with the patient and with the team. If the patient is someone who came in on MAT, which we're seeing more and more, and they're continuing on it, then there's evidence of coordination with that provider who's prescribing. So there's evidence of coordination throughout treatment. And then as that person is getting ready to kind of, move along the continuum of care, there's evidence of communication and collaboration. So, for most of us, it's obvious. This would, we would be able to tell this is happening by looking at releases of information in the record, conversations or communication notes with the providers who are administering or providing or prescribing the MAT, and a clear plan for making sure that the transition is seamless when the individual is discharging to treatment, so that there's kind of no disruption in the MAT, and that's really, really key here. So again, an MAT does not always have to be offered on site, but there's got to be a plan to make sure it's available. So whether that's through referral or coordination of care, that's got, those relationships and those partnerships have to be clear in the record as well. Variable lengths of stay is one of our final ones here. So, and this kind of goes way back to what we just talked about with individualized patient care. And Jeff talked a little bit about kind of, we're not really trying to be program driven or program focused. We're trying to be patient driven and patient focused. So does the record show consideration of the member's treatment needs and progress or lack of progress in determining treatment duration? For the person who's reviewing these charts, a pattern of patients generally staying at this level of care for a fixed length of stay really kind of screams lack of individualization. So if we're seeing, let's say we review 15 records and we see everybody has been in treatment for 28 days or 27 days, that really does say something for the most part. Maybe it is kind of just a coincidence and everybody, was gauged very closely about their progress and lack of progress. And that was the time that was best for the patient in order to move along the continuum of care. Maybe that was what happened, but generally speaking, we're looking for evidence that treatment duration is really based on progress or lack of progress in treatments. So as a reminder, a program-driven model, which is really what we're trying to kind of get away from, is what we really want to. We want to move towards that more individualized patient model. So this is where the anticipated length of stay is determined primarily by the philosophy. That's the program kind of driven. So the philosophy really dictates how long somebody's in treatment, right? So there's a graduation date, 28 days, bam, you're done. Rather than treatment that's really based on the multidimensional assessment and treatment outcomes. So there's a really nice explanation of variable lengths of stay and just some discussion on this whole concept in the ASAM text on pages 4 and then 21 and 299. Really want to point that out. And also just want to say at this particular level of care for 3.5, so this, I'm talking about 3.5 specifically here. The duration of treatment is really going to depend on several factors, but one of the most important ones is how someone is progressing and acquiring basic living skills. So how long somebody is staying at this LOC is largely dependent on their ability to demonstrate and apply coping and recovery skills so that when they kind of move to a lower level of care, they're not immediately returning to use upon being transitioned. So obviously not all issues will be resolved while someone's at this level of care, but the idea here is that we're looking at the whole kind of continuum. so that the person will continue to maybe address these and other issues as they remain in the continuum, whether that continuum is a higher level of care or that's a lower level of care. Interdisciplinary team meetings. So this is really critical for us to see evidence of because, well, it's for a variety of reasons. But we want to see that all those involved in treating this individual are kind of coming together and talking as a group about how this person is progressing, or areas that they're continuing to maybe struggle in, or maybe new issues that are kind of coming up during treatment. So these meetings are very critical to making sure that the whole person is being treated across all those 6 dimensions, and that all these areas are being reassessed throughout treatment so that we can make informed, data-driven decisions about movement along the continuum of care. So we can make decisions about maybe new interventions that we might need to pursue or adjustments to the assessment in the treatment plan. So if we have this interdisciplinary team, and I think we all know what I mean by that, but this would include, nurses, it would include physicians, it would include physician extenders, counselors, social workers, care managers, maybe UR staff. It could be security staff, it could be CRSs, really everybody who's involved in that person's, it could be family services staff. Everybody that's involved in that person's treatment is part of that interdisciplinary team. So even if we have this team, but we're working in silos, critical things are going to be missed or unaddressed, which is ultimately a huge disservice to the patient and results in subpar quality of care. This is one of the most critical aspects of ASAM, and providing that just integrated team approach to treatment. We're really making sure that every part of that individual is being addressed and it's being frequently reassessed. And after it's reassessed, then anything that's kind of coming up is being addressed. Nothing is going unaddressed. And again, you really just kind of owe this to the patient to ensure this kind of integrated interdisciplinary treatment. Okay, so that is it for the bulk of the record review preparation presentation today. And again, I know we skipped over quite a few slides, but I just want to reassure folks that this is going to be available on the website after the call today. And then a lot of what I skipped over, everything that I skipped over, is in that self-assessment checklist that I talked about earlier in the call today. Switching gears a little bit, just wanted to kind of I just wanted to make people aware of an email that was sent out last week to folks. So for programs and entities that are using WITS, there has been an update made, and it is really related to kind of the terminology that is used in the modalities in WITS. So it makes sense, but we're making sure that all the definitions and the terms that we're using are ASAM in nature. So we're kind of really removing and making sure that terminology that was associated with the PCPC is now no longer available in WITS. And so we sent out an email to kind of make sure everybody was aware of this change last week. We also did include kind of a cheat sheet for folks to reference if they were having questions about some of these new terms that are being used in the modalities sections in WITS. And we want to just let people know that if you have questions, please do not hesitate to reach out. So we just ask that if you have questions related to program setup screen in WITS, that you reach out to the email address that I have noted here. But if your questions are more about ASAM level of care in nature, if you can just reach out to the ASAM resource account, and we will, we'd be happy to kind of help you navigate through this change. So please don't, hesitate to let us know if you need any clarification on this. We're happy to help in any way. And the last thing that I want to say is that we have, we know what we're going to be talking about next month for the ASAM monthly TA call. So we're going to be talking about withdrawal management. And I know that's switching gears a little bit from what we've been talking about the past couple of months, but really excited to have Dr. Michael Lynch presenting with a couple of other DDAP staff during this call. And wanted to make people aware of a new resource that we have available on the ASAM Transition website. So you can see on the screen here, I have a little red arrow to a document that is titled The Guidance for the Application of ASAM Withdrawal Management in Pennsylvania's System of Care. So we really want the presentation with Dr. Lynch to be informed by questions that you all may have after reading this document. And so we're giving you, a little bit over a month, because the next call as you can see, is not going to be until the middle of September because of the holiday. So if you can please take a moment to look at this new resource, and if you have questions, and we're sure that you're going to have questions, please send those to the ASAM resource account so that we can have those to inform our discussion and our dialogue for this next ASAM monthly TA call. So again, this resource is available right now on the ASAM transition website. And with that, I do not have anything else today. And we have about 5 minutes left. And so if you have any questions, you can go ahead and type those in the chat. We're not going to be answering any additional questions today, but we can answer them in a Q&A after the presentation, which will be published to the ASAM transition website. Thank you for being here. We really appreciate your participation. It was wonderful to see so many people join us today for this important topic. And thank you to Jeff Thomas for agreeing to present today. That was incredibly helpful. Have a great week, everybody. And I'll just stay on for a couple of minutes. If there are questions that come through the chat, I'll be sure to add those to our Q&A list. Thank you.